So good morning, afternoon, evening, wherever you are in the world. Thank you so much for joining us for this very exciting webinar, Global Health After the Breakpoint, Evidence for What Comes Next. We had over 500 people actually registering for this webinar, which I think speaks to how timely this topic is. My name is Gavin Yamey. I'm a professor of global health and public policy at Duke University, where I lead a merry band of sisters and brothers called the Center for Policy Impact in Global Health. And I am really delighted that our center is co-hosting today's event with the global development consultancy ITAD. And the event is also being sponsored by the premier open access medical journal, PLOS Medicine. I have the great joy and privilege of being the moderator today. Before I set the scene and introduce the speaker and panelists, I have a few quick housekeeping rules. So first of all, we're going to have a short opening talk, a spark talk if you like, then a panel discussion, and then there's going to be an open Q&A with questions from you, the audience. You'll see that you can submit your questions through a Q&A function. This event is being recorded, and we're going to post the recording on our website online later today. And what that means is if you post a question with your name and I say your name, you're going to be in the recording. If you want your question to be anonymous, please say so. Second, just so you know, when you post a question, you, the poster, won't see it, nor will anyone else in the audience. It gets submitted and only we can see them. But I promise you that we will pick out the very juicy, compelling, provocative ones, not just softball ones for the audience. And there's going to be certainly differences of opinion and different views amongst the panelists. I'm really looking forward to healthy discussion and debate. Also, in general, you won't get text answers to your questions unless they're sort of very quick and factual and simple ones. Okay, so with the housekeeping out the way, let me very briefly set the scene for today's webinar. From around the turn of the century, around the year 2000, up until the early 2020s, it really was a transformative era for global health, as Derek Yak and colleagues said in their recent article on the future of global health. A period of intense multilateral cooperation, rising historic funding levels, major institutional innovations. But 2025 has been a breaking point. That transformative era is over, it has come to an end, and there's no going back. And as you know, aid donors have slashed their health funding, billions of dollars. That has triggered truly catastrophic and deadly impacts. The health aid architecture underwent tumultuous changes, and then amidst and alongside all these shifts, the health system, the global health system, is really being buffeted by a series of cascading shocks: geopolitical fragmentation, a retreat from multilateralism. There are climate-driven health crises in many parts of the world, massive human displacement from conflicts, and in many low-income countries, a debt crisis that is limiting domestic health investments. So clearly, global health governance, a big topic for today, it's being sorely tested, and that governance is going to have to evolve to match and meet these new realities. One of the most important realities, which I'm sure we will discuss today, is, of course, that low and middle income countries are calling for national sovereignty over their own health systems. The question then that we want to address today is what comes next. And the impetus for organizing this webinar, clearly there have been a lot of these sorts of webinars. The impetus is that we've seen a lot of kind of discussions and debates on, what comes next. But our feeling was that often what was missing in those discussions and debates was a dimension that we think is crucial. And that is a focus on evidence, on data, on evaluations of the global health system. In other words, what does the evidence show on which parts of the current system are delivering real impact and which parts of the system are failing miserably? What does the evidence show on what we should preserve, what we should sort of revise, what we should overhaul, what we should be abandoning altogether? So the people who know me well know that I am a person prone to drama, exaggeration, and hyperbole. But be that as it may, I genuinely, honestly, cannot think of a more wonderful group of people, of health experts, to address these crucial questions than today's 5 speakers and panelists. And I'm going to ask all 5 to briefly switch on their cameras. Their full bios are on the website. I ought to just say that just as we were kicking off, there was a fire alarm at the Wellcome Trust. So I'm not entirely sure where one of the speakers is. He might be in the middle of the Euston Road, we'll see. Our keynote speaker today is Jonani Rottingham, CEO of the Wellcome Trust. Our panelists are Ebere Okereke, who is an independent global health expert and Associate Fellow in Global Health at Chatham House. We have Sam Ferson, who is a partner at ITAD. Nina Schwalbe, the CEO of the global health think tank Spark Street Advisors and Senior Scholar at Georgetown's Center for Global Health Policy and Politics. And last but not least, Asondowo Buoji, Deputy Director of our Center for Policy Impact in Global Health here at Duke. Welcome one, welcome all. We're so thrilled that you could join us today. Jonani, please keep your camera on. The Wellcome Trust, I think, has really been at the forefront of this conversation, very heavily engaged in processes and in analyses on the evolution of the global health system, its governance, its architecture, such as the FGHI, the Future of Global Health initiative that culminated in the Lusaka agenda. You've commissioned think pieces, you funded 5 recent regional dialogues on this topic. So I'm really brimming with excitement to hear from you, and also to hear why the future of the global health system matters so much to a research funder, to a scientific research funder. So please do kick us off with your opening keynote address, Jonani. Over to you.
Thank you so much, Gavin. And it's really great to be here. And thank you to Duke University and ITAD and to everyone really for joining today. It's a pleasure to be here. I have some slides just to make sure that you have something to calm your eye on while I speak. So hopefully we can get the slides up. Thank you. Because this conversation couldn't be more timely or important, as you already have alluded to. So if you go to the next slide, I really like to step back and ask some simple questions, but that have complicated answers. What should the global health ecosystem look like, and what will it take to get there? And you see from the slide, there's a lot of different statements on the global health system currently. I'll talk about why Wellcome is involved in the search for answers, what we are hearing from countries and partners, and how evidence, sovereignty, and collaboration will shape whatever comes next. I believe we have hit a critical moment in global health, and not only a funding wobble, but a structural shift. Things will need to change, and they must change. So next slide, please. And Gavin has already alluded to this. we see aid cuts, geopolitical tension, and public distrust have exposed the fragility of the post-war multilateral but donor-led model. And there will be significant consequences. Lives will be lost and the world will be less healthy, and we shouldn't under-communicate this. At the same time, countries want more control over their health priorities. Donors want more efficiency and more measurable impact, both direct and indirect impact. And multilateral bodies need to demonstrate relevance and act with clarity. I spent a sizable chunk of this year attending and participating in global discussions on the global health architecture. They have been at the World Health Assembly, at the UN General Assembly, World Health Summit in Berlin, the Munich Security Conference, the Davos World Economic Forum, the spring and the annual meetings of the World Bank and IMF in Washington, as well as directly engaged with a range of stakeholders on the front line of global health. And everyone, I would say really everyone, agreed the system needs reform. But there is also a multitude of views of what the reform should entail. And there is no agreement on how we land the change that is required. So next slide, please. Before I get into the core themes of my talk, I want to briefly touch on why Wellcome is involved in this global challenge. Because at Wellcome, we invest in science to secure a healthier future for everyone. We support science in many ways, but science relies on a numerous global systems for really having impact. It's about regulatory systems, it's about health systems, finance systems, trade, and global cooperation. And when those systems fragment, politicize, or misalign with the people's needs, science's best discoveries go nowhere and never to the scale needed to deliver life-changing impact that we all want to see. And that is why Wellcome must engage in these discussions, because a healthier future for everyone demands a global health system capable of absorbing, scaling, and sustaining innovations and new breakthroughs to improve population health. A system, in short, that produces better health outcomes where they are most sorely needed. And as I said, Wellcome is a scientific organization. We know the power of evidence in decision-making, and we know its limitations. Since our foundation, almost 90 years ago in 1936, Wellcome has drawn on culture, humanities, social sciences, as much as natural, physical, and biomedical sciences. So we know that, however compelling the evidence is, it often isn't enough to change policies and perspectives. Science is not enough. It doesn't shift power or change whose voices are loudest in the debates. And the world doesn't suffer from lack of evidence. It suffers really from lack of alignment around what evidence counts and what evidence to act on. Next slide, please. Because we live in an information age, if anything, there is too much information. It becomes harder to distinguish the signals in the noise. At the same time, it can feel like there's never enough information. We're all making decisions with incomplete data all the time. But science can help identify the evidence, present it more clearly, indicate the consensus view, acknowledge the gaps and the uncertainties. But as I said, evidence does not speak for itself, and it does not make and should not make the decisions. We also need engagements at citizen, community, and political levels. Engagement with evidence, but also engagement before evidence generation on really what goals and outcomes should matter and to whom. Science is also about politics and power. There's no clearer example really than climate change. Research clearly shows the benefit of transitioning away from fossil fuels to renewable energy. We all know that. It will not only limit climate change, but indirectly protecting people's health, lives, and livelihoods. It will also, as an example, directly save at least 5 million lives a year, every year, through reduced air pollution. If you go to the next slide, going to COP, the UN's annual climate change conference, could be a celebration of commitment to lives saved. It's a public health common sense, really a no-brainer. But as we saw a couple of weeks ago, another COP ended without a plan to phase out fossil fuels. And why is that the case? It's the economy, of course. In 2023, the IMF estimated that aggressive climate policies would slow down global economy by 0.2 percentage points until 2030. That's about $1.5 trillion, and it would raise inflation rates by 0.1 to 0.4 points. And the investment needed to pursue those policies would not be cheap either. It's enough to make any government hesitate and focus on more immediate priorities. At the same time, inaction has also its own costs. Climate Policy Initiative estimates that losses totaling 38 trillion by 2050 if nothing changes. And if warming reaches 3 degrees above pre-industrial levels, Deloitte estimates a cost of 178 trillion by 2070. These are vast numbers. But unfortunately, the short-term cost is often more persuasive than the long-term gain, certainly for most politicians, industrialists, and financial leaders. And if the impact won't be felt for 5 or more years, especially if the biggest impact will be far away, it's easy to put it off for the future to deal with. So who can really stand up for such a long-term view? And I guess many of you here attended today, I suspect. So if you go to slide 7, we at Wellcome really want to also take a long-term view. Much of the research that we invest in is, please go to the next slide. Much of the research we invest in is discovery research. We don't know what they are going to find, and it may take decades, centuries even, to have an impact on people's health. And as an independent foundation, we can afford to make that investment. But research alone is not enough. We need a global health system that is willing and be able to apply new solutions, optimize them for specific contexts and communities, and really scale them up. Next slide. The past decades have seen huge achievements in public health, largely made possible through scientific advances and medical technology, and then delivered by governments, communities, and organizations with support through, to a large extent, international aid. Aid has had incredible impact. As we heard, fewer babies and children die young, more of us live longer, and the threat of the 3 big infectious diseases, malaria, TB, and HIV, has dramatically reduced. In the last 3 decades, global life expectancy has increased with more than 10 years, and child and maternal mortality have been halved approximately. But the system that delivers global health aid grew from foundations laid centuries ago. We should be reminded of that. Its roots are in colonialism, in the West's definition of tropical medicine, which has gradually become global health, but is still seen as a collection of single diseases, separate challenges, each with their own program to address them. Aid has shared knowledge, tools, and resources, but without shifting power. It has delivered products, but really not the means of production. It has indeed delivered improved health outcomes, but it has not delivered sustained economic and human development. The model is strained, too fragmented, too many institutions, too top-down, too dependent on donors. And really, the COVID pandemic revealed extraordinary scientific capability, but at the same time, deep systemic inequity, in particular seen in vaccine access. Aid cuts have accelerated a shift that was already asked for and coming, and asked for by leaders from the global south, and in particular from the African continent. Recipient countries want more control and more autonomy over their health priorities. The current global health system cannot deliver the next generation of health gains without substantial structural change. Incremental reforms won't fix structural weaknesses, but at the same time, overnight change is really not an option, or at least shouldn't be an option either. Tearing down what works, like accountability, measurements, technical expertise, new health innovations, all of this, to tear it down overnight is a mistake and would be a mistake. But the real tension is really, how do we govern the change processes? Who leads reform? Who sustains it over decades? Who decides trade-offs? Who balances sovereignty, collaboration, and equity goals? And as we know, the system has no steward for reform. This is always a challenge in the international space. There's no world government, and global governance is an emerging property of a network of institutions and actors, and never designed or decided on. And currently this is even harder with reduced trust in multilateral institutions and difficult geopolitical tensions, including between former allies. So genuine reform would have to challenge established institutions, positions, and interests. Change is unlikely to come from within the existing architecture alone. I think that is the fact. We need processes that are trusted, regionally grounded, engaging recipient countries and people, and capable of navigating competing incentives. We need a coalition of credible, regionally diverse stewards who can convene, distill, and discuss evidence and really call out the incoherence in the current system. Next slide, please. So Wellcome has been a key partner in a series of regional dialogues on the subject of global health reform, which brought together governments, civil society, and other actors to shape 5 regional, in a way, pitches for global health reform. We are not directing deliberations or decisions. That is not our role, definitely. But we have sought to create inclusive conversations with countries most affected by global health challenges, shaping the system that should serve in particular their needs. And we have supported 5 regional dialogues, each led by local partners, and will bring this together in a global discussion at a later stage. These regional dialogues have been led in the Latin America and the Caribbean by Tecnológico de Monterrey, in Africa by AMREF, in Europe and for North America combined Panorama Strategy, in Middle East and Central Asia, FNNet, and in Asia and the Pacific, PMAC Strategic Institute. And while these dialogues assess the current global health architecture, their main focus was really to explore what the future global health architecture should look like and which reforms will get us there. And unique insights and perspectives were surfaced in each region. But there were also a number of common emerging themes, and some of them include the need to clarify which functions belong at the global level versus the regional level, and ensure strengthening of regional capacity goes hand in hand with global reform. The second, the need to reduce verticalization and fragmentation in global health cooperation and support a more integrated care in communities. And thirdly, the need to address governance and accountability deficits, particularly those that favor the global north and donors at the expense of global south in the current system. Each of these regional organizers are producing now a report, each one of them, with the main reflections and outcomes, and which will be released already next week. And we look forward to sharing these with all of you. And these 5 regional papers will also be synthesized, as I mentioned, in a global report, which will be shared in the new year. So next slide, please. So Wellcome's support of these dialogues is only part of course, ongoing global conversations. In 2022-2023, Wellcome supported the FGHI, the Future of the Global Health Initiatives process that concluded with the Lusaka agenda that Gavin mentioned. And this has continued with strong commitments on the African continent in particular. The Accra Reset, led by President Mahama of Ghana, is calling for a transition from aid dependency to health sovereignty, as well as more broadly for international development finance reform. The Seville Global Health Action Initiative, launched at the 4th Conference on Financing for Development in July, and really aims to play a facilitator role in advancing a joint roadmap for the reform of the global health architecture. The European Commission is coordinating a reflection process of EU countries and like-minded donors like UK, Australia, Canada, and Norway, and to surface options for donors to contribute to an advanced global health reform. And this will be launched, I understand, late January. And the World Bank, the World Health Organization, and government of Japan have initiated what is called the Health Works Leaders Coalition, with the aim to coordinate efforts on country compacts that can all support one national health plan in each individual country. I also understand an agenda item on the reform of the global health architecture and links to the UN 80 reform process has been asked to be tabled at the World Health Organization's Executive Board meeting in early February. So all these processes signal appetite for change, and none alone can deliver it. So, final slide. This webinar is about evidence for reform. I have highlighted the need to use science-based solutions and make evidence-informed decisions. However, I've not referred to many evaluations and assessments of the global health institutions, their impact and their changes. Others will cover this in the panel, I believe, but I have rather focused on the why and the who. Why do we need to reform, and who should be engaged and have a voice? This is because the answers to the how questions will depend on the why and the who. Yes, we have strong evidence on the direct outcomes of improved health due to the institutions that have evolved over the last 30 years. They have delivered cost-effective interventions at scale and with health impacts. However, when I have listened to country leaders during the last couple of years, this is only one of their goals. Recipient countries want their own health systems to be able to deliver these interventions, not independent aid programs working alongside each other and often bypassing those same systems. I believe some of them are willing even to forego improved health outcomes in the short term to secure a sustainable health system for the future, less dependent on aid delivered by domestic and regional capabilities. So to conclude, the global health system we inherited saved really millions of lives, but it isn't built for the challenges we face now or will face in the future. Reform will be hard. It will require trade-offs, political courage, and new forms of collaboration. But countries are ready. Evidence for science-based solutions and integrated delivery is strong, and momentum is building. The opportunity now is really to build a system that is more equitable, more coherent, and truly shaped by the people it is meant to serve. So with that, I will hand back to you, Gavin. Thank you.
Thank you so much, Jonani, for that deeply informative, deeply insightful opening address, which I think very much kind of lays the groundwork now for the panel, which I'm delighted that you'll also join. Let me also say that when I was in London last week with my family, we took our 10-year-old son to see a very extraordinary exhibition, one of the best that I've ever seen at the Natural History Museum. It's called Fixing Our Broken Planet. I was really impressed to see that it was a partnership with the Wellcome Trust. So thank you for that as well. And I recommend it to anyone who happens to be in London. Could all the panelists now switch their videos on? Fantastic. Eberi, let me start with you. And I'm aware that there is a short delay on the videos, so the audience should just be aware of that. I think that one way to start to kind of reflect on some of the key messages of Jonani's opening talk is for you to take us on a deeper dive into what you think is working best at country level in Kenya, and what you think is ripe for reform when it comes to global health cooperation.
So first of all, thank you to the organizers for inviting me to join this interesting conversation. And thank you, Jonani, for the framing, which I agree with entirely. I want to step back a little bit to the broader issue, then reflect perhaps as Kenya as an example of the wins and not so success, some failures of the current global health architecture and the system. So I hope and I believe that Jonani's framing of this is actually an inflection point, a breaking of the system, not just a consequence of financial tightening, is true, because we need that kind of fracture to really step back and think about what we are trying to achieve. So the combination of the aid cuts, geopolitical tensions like public distrust, the macroeconomics have actually revealed something that, if we're honest with ourselves, we've always known, and that is that there's an existing built-in fragility into the system. And I want to push that thinking a little bit further. My view is that the global health initiatives, the systems that we're talking about changing at the moment, were an emergency intervention. They were designed to respond to a catastrophic set of circumstances, disease burdens, HIV, pandemic as it was, that was disproportionately hitting particularly low-income countries and particularly African countries. And most of my conversation will focus on there because that's my area of expertise. And they in a context where the health systems were overwhelmed or actually didn't have the capacity to respond. And like has been said, they worked. They expanded access to treatment, they raised coverage for immunizations, they reduced avoidable deaths, and those are important. That's great. We are not here to argue about how effective they were. However, they were a crisis machinery. It's not the same thing as a health system. So what we're facing today in Africa, for example, is actually much closer to a post-war reconstruction after a major, war conflict than to just routine development programming. And I think it's important that we look at the system we have through that lens. And so if you forgive me, history happens to be something I care about a lot. And I am always going back into history for references. So let's take Europe after the Second World War. Germany was decimated. Most of Europe was effectively the way we would describe the Africa health systems at the peak of the HIV pandemic. They were battered and dysfunctional. They were hollowed out. So the world responded, led by the United States at the time. And don't get me wrong, I'm not looking at this through rose-tinted glasses. But the response was not to create a permanent, externally run parallel system. It was the Marshall Plan. The Marshall Plan poured resources into rebuilding domestic economic and institutional capacity with a very clear, explicit objective to restore national control and sovereignty and then step out. It wasn't charity. It was political. There were power dynamics, no doubt. It served US interests as well as European ones, but its purpose was very clear. It was reconstruction, not administration. Rebuild the states, don't manage them indefinitely. And I think that African health systems deserve the same level of consideration. If global health reform only reorganizes the delivery platforms and we put a few more Africans in decision-making boards and all that, then we've actually missed the point. Because it's not just about, I agree to an extent, Yonane, the governance structures are important, but it's not just about that. It's actually about fundamentally shifting control, moving the center of financial capacity and system ownership back into African institutions. Again, like I said, I'm speaking for Africa. It applies to various degrees in other parts of the world, but I think that Africa is where the crisis and the problem is most obvious and largest. It needs to move that ownership back into African institutions. So it's not just about redesigning the model. If we redesign the model, we're just stabilizing the dependence. So it's not now whether GHIs are necessary or effective, and it's not about turning the lights off in a minute. We're not that, again, no argument about that. You can't just say, shut up shop, go away, thank you very much. It's a bit more than that. But we need to ask the questions whether they are capable of bringing forward the day when they are no longer needed. And that reform, any reform that doesn't aim towards that, any system that is not planning for its own exit, is actually not developmental as is needed today. So I'll take the question you asked about Kenya as an example. And I think it's actually a really good illustration of the current system and where it's worked and where it's not worked. So again, there have been excellent improvements in HIV, TB control, immunization coverage have expanded, laboratories, surveillance systems have improved and been strengthened. The workforce has been supported to some degree. Access to commodities have been improved thanks to the global health initiatives that have responded. But it also demonstrates where this model is actually flawed and where it's weak. It's still functioning as an emergency response parallel system rather than focusing on institutional development. So Kenya is a growing economy. There's deep political attention to health financing at the moment about universal health coverage. They're expanding their health insurance scheme. They have a devolved health system in the country now, following just over a decade and a half old, following a political shift into devolution. That requires local planning and accountability. People, citizens in Kenya need to hold their political leaders to account to deliver for them. But if the political leaders are not actually, they don't have agency over the decisions as to what is prioritized, they don't run their systems, aren't actually being developed, then they can't actually be held accountable for what their citizens expect of them. So if the key financing streams, which they are in Kenya, remain outside government systems, planning cycles are separate from government planning cycles, the workforce initiatives are driven by what the donor community, what the GHIs think are important, then it's not that the government lacks interest, it just doesn't actually have control of the levers to actually take charge. So, and that is mainly because that system was not designed for sovereignty. It was designed for delivery. And again, that's all right, that's fine, that's important for an emergency response, but that is not how we build a health system. So it's not that the GHIs failed, it's just that Kenya hasn't actually graduated from that because it hasn't been designed for Kenya, and I'm using Kenya as an example here, to graduate from that dependence. So the next reform shouldn't actually necessarily focus on, okay, the GHIs are going to do less. It's about them doing things differently. That means we need to reroute decision-making. We need to reroute the finance and accountability through national institutions so that it's more consistently owned by those country governments. And so if Kenya represents the future of African public health, then the question here is not whether support should continue. The question is what the support should be and how it should be designed. And I wanted to refer to one thing I was really particularly exercised about, and we always talk about the evidence of the effectiveness of the GHIs. But the question is, what do we even measure when we evaluate the impact of GHIs? We count, the usual things. How many lives were saved? How many children survived? How many people were immunized? Those are right matrices, but where is the measurement of how many systems were strengthened? Where's the measurement of how governments were empowered and built and how power was transitioned? We need to start to include that if we're genuinely going to measure how effective the GHIs were. I'll stop there. Thank you.
Thank you, Ebere. So not just redesigning the GHIs, but fundamentally shifting control and rerouting financing and accountability through national systems.
Yes.
Sam, you're a partner at ITAD, you co-lead its health portfolio. The title of this webinar includes Evidence for What Comes Next. ITAD has conducted many independent external evaluations of global health organizations, which I think puts you in a rather unique position to answer the question that I'm about to pose. Keeping in mind what Ebere just said, what evidence do we have about what's working and what isn't working in such organizations?
Thanks, Gavin, and thanks, Ebere and Jonan, for those thoughts and introductions. In some ways, I've got a bit of a hospital pass following up from Ebere. I think the position she's taken is very clear and something I fully support. Although I am going to talk a little bit about the evaluations that we have conducted of these organizations and what that means, less about what that means for the future. So firstly, ITAD has indeed been involved in a lot of evaluations of GHIs over the years. We've done strategy evaluations of the Global Fund, for example, of UNITAID and Gavi. We've done disease and intervention specific work for UNAIDS, for example, Gavi. And also we conducted a large evaluation of the COVAX response, which I'll talk about in a second. And we've done thematic evaluations, which I think really do speak to some of the points that Barry and others have flagged. So health system strengthening evaluations, gender evaluations, market shaping and community engagement evaluations. So from that evidence base, and Jonan flagged that we should talk about a little bit about this, we can offer a couple of reflections about things that the global GHIs do well and things they do less well. I've got two on each in the interest of time. The first one has been well covered, which is what Jonani and Ebe already flagged, that these institutions have and have proven to have an impact. We've talked a lot about data and impact, but Global Fund since 2022 has saved over 70 million lives. Gavi, since its creation in 2000, has vaccinated over 1 billion children and therefore prevented more than 17.3 million future deaths. And further than that, those global health institutions have coordinated large-scale public health responses, which are critical. COVID-19 is a really clear good example. The evaluation of COVAX that we conducted and has been well evaluated by many people documented many challenges, which I'll come to, but also highlighted that 3/4 of COVID-19 vaccine doses were supplied to low-income countries through the COVAX mechanism. So there's impact. But you're right, Barry and others, there's issues that we need to think about. The second area, which I do think is worth flagging, which is a technical area about how the global institutions can make a difference, is their work in market shaping. ITAD's evaluation of UNITAID's ARV program, for example, highlighted that the work they did with others around ARV treatment has had an impact in terms of lowering the costs, generating cost savings of over $1.6 billion to the global health architecture. Similarly, the current work that's carrying out now with the global health organizations and the donors around lenacapavir and the impact that can have on HIV prevention is working to bring the global cost down to low and middle income countries to under $40 per patient. So you can really see how these organizations work together to make a big difference. That said, how can these global institutions, what's the evidence there about how these GHIs work less well? Well, the first one is picking up on what Abere's point and really emphasizing it. The work these organizations have or haven't been able to do around health system strengthening at the country level has been ineffective, hasn't been as had the impact that one would expect. There are examples of very good health system strengthening support, often with the countries themselves and led by the countries themselves, but there's also examples of very clear disconnects between what the global health organizations think and should be done in terms of health system strengthening and what actually happens. The work we did on the Health System Strengthening Evaluation Collective, for example, highlighted how all these organizations had very different definitions of what HSS was and how it should be measured and how it should be reported. And what that meant is the countries themselves were led with many different ways about how the funding should be implemented, how they should report it, and the burden of the management of those programs sat with countries themselves. So entirely counterproductive. The second area where we want to highlight maybe GHIs could and have been less effective is the way that they have worked in reality. So, for example, the COVAX evaluation, which I mentioned before, clearly had very optimistic assumptions about how wealthy countries were going to behave, and that those assumptions came to bear, and there were big issues around how vaccines would get to countries at the right time. Additionally, it is worth flagging the global health institutions or the global health architecture is too complicated, and those organizations often or sometimes don't work as well as together they should do. We see examples of turf wars and an ability to work together coming up in many evaluations we work, and this is something that clearly we need to be trying to do to address. And of course, as building on what Abere said, lack of coordination amongst partners at country level and lack of voice at the country level around these programs. That is not to say, I need to say, that the people working these GHIs aren't working incredibly hard and trying to address these issues. That's a given. So taken together, I think there's strong evidence to say how these organizations have in the past made a difference and how potentially they could make a difference in certain areas, with certain criteria. But at the same time, I think that evidence does feed into the discussions that are ongoing now and being well articulated by our two former speakers about how global health architecture needs to change and needs to be changed radically based on this evidence base. So back to you, Gavin.
Thanks, Sam. And actually, I've already seen a question coming in from an audience member that I hope we can get to later on, which is really about the successes that you mentioned earlier, right? Lives saved, children vaccinated, the market shaping, a successful kind of financing model, and the risks of whether we're going to lose that model. So hold that thought. And that's just also a reminder to the audience to please go ahead and post your questions using the Q&A function. Asondu, you led a major multi-country program of research with research partners in Kenya, Ghana, Nigeria, India, Sri Lanka, and Myanmar, studying ways that middle-income countries can successfully transition out of health aid, out of support from the GHIs that we've been talking about. And by successfully, I mean with no backsliding and no disease resurgence when donors leave. What are the key findings from that work?
Thanks, Gavin, and thanks to Yunani, Barry, and Sam for the wonderful insights. As you know, we at the center, the Duke Center for Policy Impact and Global Health, we've worked in these 6 countries that you mentioned for several years, studying transition, focused on those countries, those middle-income countries, but more broadly looking at aid transitions globally. And one single idea has emerged in all our findings, and the fact that aid that builds capabilities always outperforms health aid that builds dependencies. And transitions fail not because countries reach middle-income country status too early or too late, but because the systems that donors were supporting were never truly integrated or financed or institutionalized. And that's important, and that leads us to a second point that we learned, and that's the fact that the biggest shock during transition isn't financial, it's institutional. Governments suddenly inherit procurement functions, supply chains, and data systems, community delivery platforms that were quietly being run by donors without input from the government for several years. And when those systems are not ready to transition, backsliding or loss of the gains that the health gains that were gained is almost guaranteed. We also found that domestic financing rises when domestic politicians, in-country politicians, see value in what they're being asked to do, and not just because the donors asked nicely or threatened. Politicians need to see the value of what they're invested in, and that highlights the fact that there needs to be in-country collective action to push the politicians to actually improve budget allocations. The budget lines can expand when the programs are visible to the public and they're politically salient, and so the politicians see some gain in investing in them, and also when they are codified into law, hopefully in situations where the rule of law works. Technical costing or cost effectiveness analysis alone has not been shown to be, it's necessary, but it's not sufficient to bring about increased budgetary allocation. So while we continue to push for those economic evaluations, we need to always remember that resource allocation is fundamentally a political process. It's not a technical one, because there's usually winners and losers. And so addressing that fact in the country is very important. Another major insight that we have had is that parallel donor systems are the biggest drivers of post-transition failures. And we see that countries that cannot sustain delivery models that were operating outside the government systems, the government rules, the government budgets, and the government HR management systems and procurement systems, these programs usually fail and after the donors leave. So when donors build these parallel systems, and especially the information systems, they also unknowingly build a future transition crisis. And we saw that when USAID was cut early this year, and several countries got locked out of their national health information systems, and they could not even access data on their own citizens because those systems were funded by USAID. And when USAID got the stop work order, they couldn't transfer them to the countries. So that's important. And speaking about vertical programs, it's great that Sam has talked about the things that global financial institutions do, the Gavis, the Global Fund, and all, and they do great work. But like Iberi said, these solutions during emergencies are not things that work well, right? When we're looking long-term sustainability, one way to think about this, and a sentiment that's echoed in many places, is the fact that of what use is it if you save a child from malnutrition if that child dies from malaria? So if you fund a malnutrition program, very well, but the malaria program is not, then you're actually still losing the child. So we need to move away from disease-focused programs to look at person-focused programs, and that's really investing in the systems. And perhaps the most important lesson that transition planning is that transition planning starts too late. We have found that on the average, transition planning starts between 12 to 24 months. But we found that for effective transition to happen, it usually takes about 5 years. And thanks to Gavi for changing their transition plans to give a longer runway for other countries, for countries to actually transition. So when transitions succeed, three ingredients are always present. There's government leadership and ownership of the core functions. That's first. There's early domestic co-financing, so it's not an afterthought where you start to bring in the government when you know that you're winding down. There's actually a discussion upfront about the role that the government will play in terms of financing and all. And then there's deliberate institutionalization of the donor-supported system. And when these elements come together, health gains hold over the long term. But when they don't, even decades of progress can unravel quickly. And we're seeing that in some countries right now with all the changes that have happened early this year and even last year. So that's the heart of all of the findings that we have. Sustainability is not an end state. It is a capability, and systems, not income classification, determine whether transitions succeed or fail. And back to you, Gavin.
Thanks so much, Asondu, for those insights. So successful transition and greater budgetary allocation to health domestically is more likely when that domestic health financing is politically salient, publicly visible, as you said, encoded in law, when you don't have these parallel systems that have been set up, typically by donors, when you've got person-focused programs, and really importantly, when there is sufficient time, typically 5 years. Nina, you are one of the most experienced global health practitioners that I know, truly. You worked at Gavi, USAID, including designing, launching, and implementing USAID's delivery of 1 billion COVID vaccines to low and middle-income countries. Worked at UNICEF, the Global Alliance for TB Drug Development, and that is just a partial list. So I suspect you've seen it all. What do you think are the dimensions of the global health architecture that should be maintained and what should be torpedoed?
Great. Thank you, Gavin, and really appreciate going at this stage in the conversation and wish we could have had just been able to ask questions to each of the people along the way. And thank you, Gavin and Sam, for including me in this. So I have a bunch of things that may sound like potentially conflicting answers, but that's because this is complex. And the other thing is, it's hard to speak from personal experience because, as we say in epidemiology, we're the N of one. So I want to recognize I'm the N of one here. And maybe the most relevant part of all the experience was leading the evaluation advisory committees for Gavi and the Global Fund, and also helping to set up those as well, and some of the challenge that we saw. So I'd like to talk about three things. I'd like to talk about architecture, evidence, and decision making. And before I go into that, I also think we need to do more discussion about what sustainability means. I grew up in a post-baby boomer world where the prevailing value was to help people. And that could be in your city, that could be your neighbor, and also to be able to accept help when you need it. So for me, there's something about the sort of, I don't want to lose our sort of humanity in this discussion because of how we get to principles. And sometimes I feel the discussion verges on that. And that's why I want to talk about this question of architecture first. For me, firstly, this is about people. And I've seen a lot of people on this call. I know a lot of the names. These are people that worked for organizations that have lost their jobs. And they didn't go into this because they wanted to make $1 billion or spend, slave away at night. They went into this because they wanted to see a better world. And I don't want us to forget that part. Okay, could the organizations have done better? Could every organization I've worked for done a better job? Were there bad people in some of those organizations? Absolutely. But I would say the majority of the crowd that works in global health really is there because they want to see a healthy globe. So that's the first thing. And the other thing is about this idea of the architecture and programs, and a lot of those programs have stopped. And I'm going to come back to this in the end, is I don't want to forget that we actually are back in a global health crisis. And I read a really interesting report by Chai that I commend to everyone that says infant early diagnosis of HIV is down 20%, 20%, and 50% of HIV positive children will die before they turn 2 years old if they're not on medication. Oral PrEP has fallen 37%. So I just don't, we are actually in a crisis right now, and I sort of don't want to forget that, because I do worry that we throw my favorite phrase is don't throw the baby out with the bathwater. And as somebody who's worked in pediatrics, it's kind of offensive, but it's also extremely kind of meaningful phrase. So that's the first thought. The second thought is about the evidence, and building on actually what everybody has said before is, unfortunately, a lot of the evidence that we're working off is weak. And it's not because Sam and his crowd don't do great work, or a lot of people on the call as well. I noticed colleagues from Gavi, the Global Fund, who are doing great work on evaluation, but first, too little spent on evaluation. We're squeezed. These billion-dollar programs have chronically underspent on evaluation, and despite a constant plea that evaluation, doing it well, costs some money, it just doesn't happen. And the evaluations are also difficult. They're complex, and we have very little appetite for complexity in our world. It's all about the sound bites. We just wrote an article, a commentary, which talks about how, like, the headlines, we focus on the headline news in global health, and we never talk about precision. We focus on point estimates. We don't talk about uncertainty. So we've sort of oversimplified how we talk about global health. And that also hasn't done us great service. And that also leads into this idea of, when we do have evidence, there is a success cartel. And those evidence, and those of us who've worked on evaluations for some of these global health organizations know that a lot of the organizations that commission us really tightly control us. And they put commission or committee after committee upon us. And they really don't want independent evidence. They don't want to throw it open to what could change or what could be different. They kind of want to hear things they already know. And one of the most disappointing things when you present evidence to a global health group is they're like, you're just telling us stuff we already knew. And it's like, yeah, that's because you controlled every step of the process in how we had to conduct this evaluation. So of course, and you actually redacted our final report. So the success cartel also isn't super helpful in trying to get good evidence. And then when you do have good evidence, it's incredibly hard to get it into decision makers' hands. And I'll give you one example of that, which was when I was at Gavi for many years and we were setting up the evaluation function. And this doesn't implicate anybody currently there, except maybe Jan Arn, who I think was on the board at the time. We could not get that evidence in front of the board. We would argue board meeting after board meeting for a day prior to the Gavi board, when we could say, we've just collected all this awesome evidence. Can we present it to you before you make decisions? But no, it was like, we're too busy. We're doing other things. So this is the point, is even when there is good evidence, it's often ignored. And I want to come back to the HSS, because that's something I was very involved in the early days. In about 2009 or 10, there was a big push with the Paris Agreement that everybody's forgotten about, and the Paris Principles, to try to merge Gavi and the Global Fund's HSS. And out of that, we started to call for an evidence base. It was like, oh, we don't want to do this because we don't want to throw out what's working, so we need an evidence base. And I swear, 10 years later, we couldn't get that evidence base because people just aren't interested in seeing sort of honest criticism, I think, of their program. So we could talk a lot about just that HHS example and do a whole seminar on it. And finally, it's about decision making. And I think this is going back to the architecture discussion and away from the evidence discussion, but back to the people part. What worries me a little bit about the global health architecture discussion is that it still seems pretty top down to me. And I appreciate that there have been open forums, and Wellcome has, tried to get these regional consultations. But when we talk about decisions being made or conversations at Berlin or at Davos or at Chatham House, those are not open. Oh, I'm sorry. Pardon me. About that. Those are not open decision-making forums, and they're not kind of up for the people. And we've talked about putting a lot of faith in government, which I think we have to worry about.
Nina, you went a little bit quiet. Can you put your volume up a little?
Is that better?
Nina?
Is that okay? Yeah, it's good. Great. Sorry about that. So we talk about, about having people engaged, but we're really talking about having government engaged, and we're really not figuring out how to have the people affected by service programs or frontline people really engaged. And of course, that requires investment and money to do it, and a lot of other technologies. And I just want to give one example before I close about that. The pandemic treaty is something I've worked a lot about, and it's really about, in many ways, the future of multilateralism. There's a lot of lip service about engaging stakeholders and engaging civil society in the discussions about how we are going to govern future pandemics. And once again, member states made a decision that stakeholders cannot be in the room. We're invited in the room for the first 15 minutes of the discussion. Great, we get to give our statements. There's some wonderful pictures on the internet of that, of like the member states don't even show. That's when they go get their coffee break. We give our little statement, and then we're kicked out of the room. So I think I appreciate this, but I don't think these discussions can be happening at Davos and Berlin and at Chatham House. I think if we're really going to talk about this, we have to figure out a way to open it up and get regular people involved, because those are the people that are going to hold our governments and every government accountable for the changes. All right. Thank you.
Thank you so much, Nina, for reminding ourselves that we must never forget the human side, that we must never forget the people part and the people who are at the center, and for also reminding us that too often these conversations are happening in a very top-down way. We're going to get to audience questions very shortly. I have a question for Yonani. You have said before, Yonani, that the global health architecture has been good at delivering results, but it's not necessarily functioning well as a system. And I wanted to ask you a little bit about that. You talked about earlier the Lusaka agenda, the FGHI agenda, the 5 regional dialogues. Clearly, the Wellcome Trust has played a leading role in driving analysis around the architecture and around possible reforms. What do you think are some of the lessons from that analytic work as it relates to the systems side that you have said, not so great at?
No, thanks, Gavin. I think it's first really important to be clear on what the functions the system should provide, and in a way have a principle that it should be delegated to the nearest the people as possible. And I believe we have seen a trend, including from the GHIs, that in line with Nina is saying, decisions and priorities are made very far away from both the communities and the people, but also far away from the governments who really need to be responsible for delivering health for their people. So from a systems point of view, I think we need clarity on what kind of functions that should be provided at country level, at regional level, at global level. And of course, there are many sort of sub-levels in between and a different architecture, different context in the regions, but really starting country by country. I think some of the questions from the audience here is challenging, though, because I think we need to understand that it's not one size fits all for all countries. We know that in some countries we do not have strong enough institutions to protect and promote human rights. How do we go about that? That's a really a difficult dilemma, because if you have a democratically elected government and then not prioritizing marginalized group, how do we think about that from a global normative point of view? I think it's not an easy solution. I just wanted to state that. The second is really countries that are fragile and in conflict settings and where even governments do not have control in all of the territories. How do we deliver health in those settings? But those are all, I would say, not the mainstream. I think the mainstream need to be and make country governments accountable for the health of their population and have that as a starting point. And then external support, technical assistance, global public goods, regional public goods, external finance can be a way of both incentivizing and making sure that increase the likelihood of governments succeeding. We have seen a reduction in on-budget support almost systematically from many of these global health initiatives over the years. That's linked not only to their incentives, it's also linked to the risk averseness from donors. And I think actually we need to take more risks. We need to really invest in public finance management systems, and because I think there is a clear global consensus on universal health coverage and collective finance of healthcare in countries, and we need to build those system capabilities. So yeah, some reflections.
Thanks, Jon Arne. So no one size fits all for all countries. We have many questions that have come in. I'm going to try and see if we can get through as many as possible in the next 23 minutes. And I'm going to try and group a few where they're kind of thematically similar. And I'm going to start with questions from Louisiana Lush, Essie Lindstedt, and Anitha Athiyayam, which are saying sort of similar things. They've all asked about kind of different pathways out of the existing system. Louisiana has brought attention to the trade-offs that might be necessary between replenishment of the GHIs, maintaining the powerful networks of advocates who have galvanized the global health system to date. Essie asking about what we should be advocating for now to bring about a kind of orderly phase out. And Anitha asking whether it makes sense to target funding towards a particular subset of countries, perhaps those that are in the least developed categories, the LDC category. So panelists, any reflections on sort of pathways forward that would bring us some kind of orderly process?
I mean, one thing I'll say is I think we can fully fund the Global Fund because we know that we can't throw the baby out with the bathwater, and we know they hit about 60% of their target, and they're willing to work on an orderly transition. And all governments took this opportunity, every single government, to drop their pledge. So that would be, as advocates, something I think that we can do, and then at the same time, help them work on orderly transition.
I'd start at the other end. I think we need the Accra Reset, the Accra Summit, the sustainability agenda for one is one way of beginning to look at solutions, which is governments actually stepping up to their responsibilities. It's not just, it's not just rhetoric about saying health sovereignty. It's actually committing through domestic investment, through accountability, improving the transparency of how you use your spend. We can't just look at one end. I think we need to look at the system that has to replace the Global Fund at some point. And I'll stress again, I am not saying turn the lights out of the Global Fund, but if we still just focus on the GHIs because they work, we will 10 years time, we'll be having this conversation again. We also have to start to look at how do we support the country, the governments at national level, and some of the questions that were raised about what happens about communities and special key populations are more vulnerable in each country. We have to start somewhere. And for me, the closest place to start has got to be at national level before we start looking at the global systems or regional. Regional architecture has some role, particularly in the more complex or the more rare situations. But in terms of looking at the health system holistic, we've got to support these movements around health sovereignty and to move away. I've been in a room in a ministry in I won't name the country, where the health minister went with his proposals for increasing budget for spending, and the finance minister says, I don't need to give you any money, you can go and get it from the donors. We've got to change that. And for me, that is where we start.
Barry and Nina, I've got to just post this question immediately since it's so relevant. Ana Maria Bejar, Director of Public Policy at Gavi, asks, how do you see regional, country and community views being integrated into these solutions going forward? How does one do that?
I have a question maybe for Barry, building on that, which is back to what Jan Arndt said. So, I mean, and we're facing that here as well. We're facing that here as well now. But so, what do you do about marginalized populations? What do you do about queer people, drug users, people who have been served by more of an international community of solidarity versus by any national or by private sector philanthropy versus any national government when we go through that transition period? How do we, what's your thinking around that?
The sort of the reading between the lines of that question is to suggest that there aren't marginalized populations and communities in the countries that are making their own health decisions. They are. And the challenge is the same, whether the decision making sits at national level or sits out with. But in my view, we can't say that because they're marginalized communities in poor countries, that is a reason not to give them sovereignty in their health priorities. We need to, part of that, for me, the most important solution for sovereignty and agency by any country, first of all, is actually citizen engagement. This is not about technical interventions. This is not necessarily it's not even about money. It's about politics. And politics, I mean, global health is politics. If you're trying to change the health experience of populations, it's political. And the biggest way to solve that is actually to engage the grassroots. People need to have to hold their politicians to account. One of the examples I always give is that if your political parties don't even mention health in their manifestos, then you have a problem. There isn't going to be any sovereignty, no health sovereignty there if it's not seen as a priority for the electorate. Whether you get voted in or not doesn't depend on what you propose to do for health. So I agree that it's important to make sure we don't forget the needs of the marginalized, but marginalized and vulnerable populations exist in every country, whether they are directly controlling their health system or dependent on donors or external agencies to address them. So I don't think we can paint it as an either or in this conversation. I stress again, I am not saying that the global funds of the world are irrelevant. I am not saying they're not consequential. And we're using just global fund. I'm sure we all recognize that there are multiple others here. And I'm not saying turn the lights off. There has to be a transition. And part of that transition is the work we need to do at the grassroots level to make sure that minority populations are not forgotten. But this is not a unique circumstance to donor-dependent countries at the moment. It is a global issue. We don't have to talk about the current, what's going on in the United States at the moment, for example. And the Global Fund is not operating there. So that's not I think the issue is global, of marginalized populations, vulnerable populations, making sure that any transition and any health agency doesn't leave them behind.
Sam, I see you have your hand up.
Obviously unmute my audio. Just to add to the debate, this is exactly the kind of conversation I think we want to be having. It's really great to be engaged. Just a nuance to this discussion we're having. Obviously, I fully agree with the point just made about the fact that marginalized populations are an issue that's global. In the UK, it's the same, and elsewhere. But one of the nuances around, for example, the Global Fund model, and in some cases the Gavi model, is that the way that there have been very significant successful programs which involved, community country coordinating mechanisms involving the right stakeholders at the political level, at the country level, to help make those decisions, which themselves have been proven to have an impact and have played out to inform how those countries can be operating better and how programs can be better targeted. And that's a nuance, and you're right, it shouldn't necessarily be done to those countries. It needs to be done with those countries and led by those countries. But building up those systems and structures in across those countries, indeed, as it should be in the UK and US and elsewhere, is something that has to be a common good and has to be something that needs to be supported. So my concern is that I know we're not saying like let's turn off the tap, but if we don't build on what's already been there and those systems that are in place, we're going to be we could retrench quite quickly into a much more difficult situation. I think some of that is happening with the USA cuts, and we're seeing that already. So I think we do need to be a bit more nuanced about what we have and where it is. I fully agree the direction travel needs to be in that way, but I do think there are systems and processes that have been big successes in the way these global health organizations have tried to push the country ownership and engagement through that process. One quick other thing to answer the question that someone's asked around where we could focus the conversation. Market shaping, I talked about that in very general details as a big success. There's clearly a political impetus for market shaping to be led by regions and countries, and the COVAX experience is a good example. So I'm not saying let's keep market shaping with the global health institutions, quite the opposite. But the lessons and experience of how that can be done should be built upon, so regions and countries can do that themselves and do it better. And that's another way forward. So I do think there's lessons that we can take about what works really well and has worked in the past: community engagement through CCMs, market shaping through the global networks, that can be built upon at the regional and country level.
Thanks, Sam. Sondu, you had your hand up, but it's down now. Do you want to add?
Yeah, I just wanted to say that I think we have an opportunity here that we shouldn't let go. The global health community is painfully waking up to the reality that aid is not forever, and aid is never sufficient. And the future of global health systems and global health performance in low and middle income countries is actually domestic resource mobilization, increasing that. And I think that we should use this as an opportunity to move towards that goal. Two tangible ways to begin to look at that we've seen that has worked, and it's been adopted by several countries. There's service integration, and there's also financial integration, right? So where you're able to now integrate the services, typically the services that are funded by the large global health institutions and all the vertical programs, moving them into the existing healthcare system. So moving away from what we traditionally call vertical programs that operate outside the country system and then fail after the donors leave, but moving them into the government system. They might grow slow too, but eventually they last longer. There's also the question about financially integrating them. Right now, you see the Global Fund is beginning to look at alternative sources of funding for HIV positive people living with HIV in many low and middle income countries. They're exploring national health insurance plans. They're exploring corporate social responsibility, thinking about bonds. I think that these are things that we could move towards so that we don't find ourselves in this same spot several years later asking, what do we do because there's a new aid cut? Speaking specifically about the vulnerable populations, we found that there are real issues about some countries not being able to provide care for vulnerable populations. And in some of the countries that we studied, mostly from Eastern Europe, when they were transitioning out of Global Fund aid, the Global Fund actually supported them to be able to allow their civil society organizations receive money from the government, because prior to that, the government systems did not allow civil society organizations to receive money. And so those populations were at risk. But by the Global Fund helping the government to institute those kinds of systems, create line item budgets, and also in places where it's difficult to engage outside the government systems, working with the government to make sure that that happens years before the final transition, that showed significant success in the countries where that was done. But in other countries where that was not done, there was actually an increase. Abrupt pulling out of Global Fund led to increases in injection drug users, HIV incidents in injection drug users by more than fivefold. So I think we have this opportunity right now. It's a crisis, but it's also an opportunity. And if we're one way we can begin to move in a good direction will be to start thinking about integrating current services and finances. A lot of people would lose power, right? Because you're now transferring power to government systems. But I think that if we have the big picture, if we always remember the big picture, which is better health over the long run, that shouldn't be a problem.
Thanks, Sondu. I did say that I would bring some of the kind of juiciest, most provocative questions to this panel. And I think this one might be the most controversial, but also really important. And this might be a little bit mean of me, but I'm going to ask Jon Arne, first of all, to address it. It's an anonymous question, and it asks the panel to reflect honestly on this question. The anonymous questioner says, look, let's take it as a given that there have been positive impacts from many of the global health initiatives. But, what has significantly changed? Why should countries trust those who have been responsible for creating this confusion now, this initiativitis, says the questioner, which led to multiple attempts at coordination of the global health architecture, IHP plus, GAP, UHC 2030, and. Why should we trust those, the questioner asks, that created this chaos? Jon Arne, as I said, I'm going to ask you to reflect on that first and then open it up to the rest of the panel.
It's an excellent question. And yes, there have been many attempts to try to integrate, to coordinate, to be more coherent, and to work more alongside country priorities and plans. The question is really, why should we trust the current efforts of reform more than, based on what we've seen in the past? I may actually think differently in some way. I would say that we should not trust. I think actually now it's the time to not trust the system to change. That's why I am really optimistic regarding the political leadership that is emerging, in particular from Africa, to really demand and call for self-reliance, but also then demonstrating a political will to do more in their own countries. We've heard Nigerian health ministers, finance ministers saying twice that they can deliver the HIV program at the 40% of the cost of what the external funders have delivered in the past. So I think, and they should not trust the system to make them do that. They should actually demand it. I think it's the point now is that we need a coalition of leaders from the global south that actually can together demand the change they need to see. So yes, it's really positive what is seen from the Health Works Leaders Coalition, where the different larger multilateral funders are coming together and say they want to align through national compacts with government plans. But I think at the same time, we need a strong coalition from countries saying that we demand that you actually deliver on our needs. And that is can be quite a difficult negotiation. We know one country now, and we've seen the templates for bilateral agreements that are quite demanding on countries what they expect from recipient countries. I think the only way to address that is actually a collective voice from the global south and from the continent of Africa and from the other. So no, I don't think they should trust. They should organize. They should get together. They should use the political instruments and institutions they have. And then, of course, we need people, communities, societies, both from the global south and the global north, to hold both what is traditional donor governments and sort of partner country governments to account for delivering on the political will they are signaling, and avoiding that too much political sort of conditions are put into driving us away from what we want to see, health improvement and better health.
Thanks, Jon Arne. We've only got 5 minutes left. I'm going to try and squeeze in one or two more questions if I can. We've got two questions from Julianne and Masuma about the conditions ahead around donor exits, country ownership. What conditions should governments demand from donors? And are donors and GHIs really ready to change and exhibit the level of flexibility required to address countries' needs? Who might want to take that one? Ebere, you're smiling. I'm going to take that as a yes from you.
No, I wasn't actually, but That was wind. Turkeys don't vote for Christmas. I think that's a given. Despite their best intentions, this humanity tends to default to the status quo. We like to stay in the status quo. We might tinker around the edges. So the actual drive to change things, to make things different, has got to come from the countries themselves. And Yonane has already talked about some of the initiatives that are emerging. And it's again, and I think it's important to stress that we're not throwing the baby out with the bathwater. And we're not saying, thank you very much, no more cooperation, we'll do it all on our own. We're just saying we need to be part of, and preferably leading, the design and the prioritization of the health needs for our own populations. And that needs to recognize that there is a power imbalance, of course. The GHIs have, and the philanthropies and the donor countries, I have concerns we use in donor countries, as we've just demonstrated. The African countries are as much donating to Global Fund, maybe as a proportion of their investment, it may be smaller, but they're donors to Global Fund as well. And I appreciate, again, I keep stressing for those Global Fund colleagues online, we're not picking on Global Fund. It's just a very easy example to use. They need to lead the drive to take back agency. They need to do that. They need to address some of the challenges. That is, how do you mobilize resources domestically? And there are lots of mechanisms for leveraging resource, even in this financial constraint, that have not been fully exploited yet. How do you address accountability? There are things around transparency, using data, using innovation, and all the, we can't go through any panel without mentioning AI at some point, that can actually improve the use of the resources you have and the transparency, because you need to also develop trust. Because let us not pretend that there isn't a big trust vacuum, both in terms of citizens and their expectations of the government, but some of what we're hearing here, which is also the GHI is not actually confident that those governments will deliver the best services for the resources that they have, which is why we end up with multiple MEL systems, by that those same governments have to use the limited resource they have to try and reassure the donors that they are using their money accountably. We mentioned Nigeria and Pate here, and I am a huge fan of his one plan, one budget, one MEL plan. That is the sort of approach you actually now have to say. It was what Rwanda did after its genocide to rebuild its system. They set the plan and they said to donors, these are our priorities, align with us or thank you very much. Now, they took a risk, but that risk played out. And I think if we are to believe that we all genuinely believe that the current system has to change, then that does actually require us to take a leap of faith to an extent, not blindly. We do need to say to the governments, when they talk about health sovereignty, you need to actually demonstrate what that means. But we do need to take a leap of faith and to have some patience. So to allow those national governments to grow their systems, to strengthen them, to try, to fail, and to succeed. The only failure is if they never try, but they have got to be given the space to try.
Fantastic. I'm pleased you smiled or had wind so that I could ask you that. One plan, one budget, one MEL plan. That is a fantastic place for us to stop. I have to just thank Ibshita Barali at Duke and Pippa Page Lowe at ITAD and Alicia Gonzalez at Duke, as well as the panelists who've been helping me read through and select the questions. Let me just say that obviously there's a lot of questions that we couldn't get to, but we are going to kind of look at them and find some way to capture them. Perhaps we will all write a blog together or something like that so we can continue. I saw a terrific question on health research from Derek Yak that we couldn't even get to. So I need to wrap up. I feel like we could carry on talking all day. I'd like to say a truly huge thanks to our really wonderful keynote speaker and our 5 panelists, Yonani Rottingen, Ebere Okereke, Sam McPherson, Nina Schwalbe, and Asondu Ogwoji. I am hereby giving you a massive digital round of applause and a digital standing ovation. Thank you so much. I need to say a huge thanks to Michael Penn, Caitlin Shepherd, Lee Walls, and Alicia again at Duke, and Carol Smithers at ITAD for magnificent logistical support. And finally, thank you, the audience, for joining us today. There were about 300 of you, and for posting such terrific, thoughtful questions. We are going to share the recording of this event by the end of the day on the DGHI website, and I will also post the link on LinkedIn and on Blue Sky. Have a great rest of your day. Goodbye and farewell. Thanks so much for joining.